Okay, I'll just play this. Okay, everyone can see my slides?
Yes. Okay.
All right, I'm going to talk about mechanical circulatory support in cardiogenic shock. Basically, ECMO to impellers, and then potentially VADs for those patients, so ventricular assist devices, for those patients who remain in severe heart failure. So just to set the scene very briefly, this talk's not going to be about how to manage an ECMO patient, but just to quickly go over how it works. The modality of ECMO that we use for cardiogenic shock is veno-arterial ECMO. So what you have is a venous cannula that sits in the IVC via the femoral vein, and it drains blood into a pump, through into an oxygenator, and then it returns oxygenated blood via the femoral artery. So by virtue of the fact that that circuit is actually pushing blood into the aorta, you're going to increase your MAP or your afterload within the system. So it's not a physiological form of support. You've got this heart that's in cardiogenic shock that's failing, and it now has to eject against this really high afterload. But it's the best we have at the moment for cardiogenic shock, and it's particularly the best that we have for those patients that have biventricular failure. And we know that a lot of patients in cardiogenic shock have biventricular failure. And it's definitely the best option that we have to be able to perfuse the end organs and preserve organ function. Because the biggest cause of mortality in this patient population is the multi-organ dysfunction that ends up occurring. This is an impeller. Impellers you might be hearing more and more about at the moment. They're basically a microaxial pump. They can be inserted percutaneously in the cath lab by the cardiologist, or they can be inserted by the cardiothoracic surgeons via the axilla. What happens is they place the pump across the aortic valve, where the pump will drain blood from the LV, and then it will return it across the aortic valve into the aortic root. So it sounds like the ultimate solution for someone in cardiogenic shock. It's physiological, it mimics the LV, it's a small device, but it's really not that panacea that the reps try and tell you that it is. They're really expensive. They frequently migrate, and they're really fiddly to place. They also consume a lot of heparin. So despite what we're being told at the moment, the evidence really isn't strong for its use in cardiogenic shock, but it's something that we are using at Westmead and RPA to vent the heart when we're supporting them with ECMO. Now, when I say vent the heart, I'm talking about unloading the ventricle. So you can see on this diagram here that peripheral ECMO, it's not like full cardiac bypass. You're still going to have some circuit circulation and some native circulation present. By that, I mean that not all of the patient's cardiac output is going to be. So you're going to have some blood that's ejected and drained through the lungs and back to the LV. Now, if that LV is not ejecting properly, then you're going to have some blood that accumulates within the LV cavity, and you'll get some LV distension and pulmonary edema. So we use the impeller to drain that excess blood. Now, there's a couple of peripheral centres in Sydney that are starting to use the impeller in lieu of ECMO retrieval, and there is probably going to be a need for us to retrieve these patients on an impeller in the near future, and we're slowly starting to tease that out. Finally, we have a more durable form of mechanical support. They're currently not being offered as destination therapy, so they're a bridge to heart transplant. If I have time at the end, I'll probably touch a bit on it because I've been asked to talk about VADs as part of this talk too. So I want to start off just by talking about a retrieval case to set the scene. It was a 59-year-old male. They had chest pain and then had an out-of-hospital cardiac arrest at 2 p.m. They received 6 shocks over 2 separate episodes, so they had a low flow time totaling about 20 minutes. They got to Blacktown and they had another PEA arrest with a rapid ROSC at 1700. Apparently, there was some neurology demonstrated by the patient with some eye moving, and they were told that the patient was functionally independent at home. The ECGs showed a STEMI. At 5:30, at the time that the retrieval team arrived, he was on double-strength adrenaline and noradrenaline infusions, both running at 10 mils an hour. There was evidence of pulmonary edema on chest X-ray, and the SATs were 93% with a PEEP of 10. So the retrieval team packaged the patient up and transferred to Westmead for a salvage PCI. At 6:30 p.m, he arrived at Westmead and he had a marked acidosis with a pH of 6.9 and a lactate of 6. Now, part of that might have been respiratory, given that he was in pulmonary edema. So being an ECMO talk, it's pretty obvious where this is going. And the patient was referred for ECMO at 8 p.m, 6 hours after the initial insult. What becomes interesting, though, is, and what's going to be the centre of this talk, is when should ECMO be activated? And in this case, was it potentially activated too late? So we're going to talk about AMI cardiogenic shock first. It represents about 80% of all cardiogenic shock cases. And the literature tells us that about 10% of these patients, despite having revascularization, will still go on to develop worsening cardiogenic shock. And the culprit trial demonstrated a 40% mortality in this patient population. There's a growing body of evidence that VA ECMO in the use of AMI cardiogenic shock facilitates your myocardial recovery. And it does this by resting the heart, reducing the myocardial oxygen consumption, and it simultaneously augments your end organ perfusion and coronary blood flow. Essentially, I guess what ECMO is doing in this setting is limiting the extension of the infarct, and it's also preventing that multi-organ failure. Now, there's going to be a lot of nuance to this, and the best results are when the heart is vented or decompressed, so you limit that wall tension, but we won't get into that. I guess not just AMI cardiogenic shock that benefits from ECMO support. We have distributive shock, and those patients have a 60% survival rate if you use ECMO early enough, and the septic cardiomyopathies do incredibly well as well. So given the fact that the evidence is starting to significantly and substantially increase towards the use of ECMO in these shock patients, there's a strong urge and push to have these patients referred earlier. And there's good reason to believe that setting up ECMO early before that refractory shock sets in is associated with the improved survival rates. Now, on the screen, I'm showing you the SCAI stages of cardiogenic shock, and I'm not sure if you went through this morning. But previously, ECMO referral was only considered when patients had reached that stage D deteriorating phase of their pathology, transitioning into stage E extremis. But I think the evidence really now is showing that that's just too late. Your mortality is 4 times higher when you've got the liver dysfunction. It's 6 times higher when you go into renal failure, and it's obviously going to be, it's about 20 times higher when CPR is in progress. And that's often, unfortunately, when we're called. So the markers of perfusion that you have in these shock states when that patient's transitioning into stage C, so the elevated lactate, are actually quite late signs. And the multi-organ dysfunction is probably already setting in, and you're already starting to cause damage and have an impact on their mortality. So the opportunity to actually prevent that irreversible damage has probably been lost if you wait for that lactate to climb significantly. So the message here is that we need to start thinking about cardiogenic shock as a time-critical pathology that requires early assessment and intervention, and it requires a multidisciplinary input from the start. So not just an ECMO team, but you've got the intensivists, the cardiologists, the interventionists, all putting their heads together to sort out these patients. The SCAI recommendations now are to consider ECMO implantation when a patient's in stage C. But in some European centres, that referral is occurring even earlier, and patients are being considered in stage B of their illness. So these are patients that are demonstrating signs of splanchnic insufficiency like vomiting and nausea. And when you speak to Alain Coombs, who runs one of the biggest ECMO centres in the world in Paris, he will tell you that the earlier you place ECMO, the less likely you are to intubate them. So he's commencing VA ECMO in patients that have not yet reached the requirements for intubation, because he knows that the main issue is that circulatory. So what does it mean for us clinically? It doesn't mean to replace one big tube with a bigger tube, but we want to be thinking about mechanical support for patients that have a blood pressure less than 90, have lactates more than 3, cool, clammy. They've got signs of that splanchnic insufficiency. They're awake though. They might be confused. We don't want to be waiting until they're on escalating doses of inotropes with significant multi-organ dysfunction. Now, if we initiate ECMO support prior to revascularization in the cath lab, there is evidence to say that you're actually going to preserve more myocardium and you're going to limit the extension of the infarct. So it's counterintuitive. You just want to crack on and revascularize the lesion, but it pays off to wait, establish ECMO support, establish organ perfusion, revascularize the heart, and then they should do okay. So ECMO was once considered a therapy for these patients that were in extremis, and it was that last Hail Mary before they died. And we're moving away from that model now, and that focus should be, and we're working towards that focus being on preemptive implantation and preventing that multi-organ failure, because we know, as I was saying, that that is going to be the major determinant of mortality here. And it is why normally in ICU they would withdraw care. So now I want to turn our attention to the other side of the heart, the right side. So acute right heart failure is even more challenging to manage than your standard AMI cardiogenic shock. And management with both MCS comes down to that principle of ventricular interdependence and understanding it well. So here we have a 45-year-old female that had a history of an unprovoked arterial and venous thromboembolism. She had anticoagulation interruption because she had a lot of bleeding at home and was anemic. So she hadn't been taking her apixaban. She presented strike. Her HB on presentation was 69 and she was still bleeding. But at the time of presentation in ED, she was alert. She had a stable BP. She had a grumbling tachycardia and she was hypoxic. The CTPA demonstrated a moderate clot burden, so she had a central component and it was mainly in the distal PA. There was no saddle though. She had RV strain present on the CTPA and there was a possible PFO reported. So they activated a PERT call at 6:45 and they decided to take her up to angio to do catheter-directed. In the anaesthetic bay, they did a quick echo and it demonstrated a hyperdynamic LV. She had RV dilation with moderate to severe dysfunction and a TAPSE was around 8. She was tachypneic. She was unable to lie flat. She was desaturating to 86% and she was on 15 litres of oxygen prior to anaesthetic induction. However, she tolerated the induction and was stable for about 45 minutes on milnirone and NORAD with MAPs of around 70 to 80 and SATs of around 92 on an FI2 of 80%. But at 9:45, her NORAD requirements started increasing. She became more tachycardic and more hypoxic, and her CVP jumped up to 28. At 10:40, she had an episode of VT and her BP dropped with that. And she was shocked into a sinus tachy again and her BP sort of stabilised. They defended the BP with large doses of NORAD, adrenaline, milnirone and vasopressin whilst they mobilised us, the ECMO team. And her SATs continued to hover around 70 to 85%. She arrested with a low flow time of 5 minutes as the ECMO was established. So the toe following ECMO initiation showed a severely dilated RV, severely impaired function, a dilated main PA, but we couldn't see any clot, normal LV and the aortic valve opening. So one of the trickiest decisions we have is the timing of VA ECMO support. Obviously, it's not without risk. It can cause limb ischemia, and that's a very real risk of losing your leg when you place these arterial cannulas in the femoral artery. Bleeding, stroke, and we don't want to do it as unnecessarily. But at the same time, if we do it too late, where we've kind of wandered into that realm of multi-organ dysfunction or even cardiac arrest, then it's obviously pointless and futile. And the teams, particularly at Westmead, are so used to batting on with unstable patients that it doesn't even occur to them that ECMO may be an option. Arrest. In this case, though, I think there were some key key, very clear inflection points where an earlier referral may have been of benefit. So the first one was the CTPA. That demonstrated a right heart strain, pressure overload, and there was a PFO there. Now, this lady had an undifferentiated thrombophilia. She had clot in her right system, and she had a PFO. So without decompressing that right side that's now pressure overloaded and reducing that pressure, there's obviously going to be a significant risk that any other clot in her venous system is going to fly across. The second opportunity was when the echo is being done in the anaesthetic bay. So there's, again, clear evidence of RV strain and reduced RV function. The patient's on 15 litres of oxygen and still desaturating, and they're tachypneic and can't lie flat. I don't know, in my experience, it's quite unusual for PEs to be that hypoxic. There's some hypoxia, but they're not that hypoxic. And that told us that there was a shunt present, and that the right-sided pressures were higher than the left, and they were causing that deoxygenated blood to go across the PFO. The third opportunity for an ECMO referral came at 9:45 when her NORAD requirements increased and she was becoming more tachycardic and hypoxic. She's now intubated, you've added positive pressure into the system, her intrathoracic pressures are high, her PVR then is going to be high, and she's going to have a reduction in her venous return. So that increased in pulmonary vascular resistance is going to increase your RV dilation even more. It's going to reduce your LV filling, and it's going to make you go into that low cardiac output state that's associated with a massive PE. That low cardiac output state is going to reduce your coronary perfusion. It's going to further impair your RV function. So she's now circling that drain of RV failure. And once that spiral starts, it's really hard to bail yourself out of that. I don't know if this is going to play. No, it's not. But this was going to be a really great echo of someone with an acute PE that has that poor LV filling and RV dilatation causing the shock state. So the last opportunity, or the fourth opportunity, I should say, came when the patient went into VT. Obviously, that's indicating that there's poor coronary perfusion happening, and she's becoming more and more ischemic. And then finally, the referral came when that BP was defended with really high doses of NORAD, adrenaline, milneurin, and vasopressin. And just as we were inserting sheaths, she arrested. Now, she remained on ECMO for 7 days and was successfully weaned off, but she suffered from bilateral MCA. Clot did travel across the PFO, and that resulted in a dense right hemiparesis. She's home now, though. I was going to talk to you about ECPR, but I think that we don't have enough time to do that, and I think I might save that for another day. I guess ECMO in this case, though, would have been useful to reduce the workload of the right heart. It's a really good tool for RV support. The venous cannula sits in the RV, it drains the RV and reduces the volume it needs to eject. Just try and get that there. Filling of the RV and decompressing your chamber size, then you're allowing your LV to fill again, and you're effectively increasing your cardiac output. If you reduce the pressure in the right side of the circulation in the presence of that PFO, then effectively you're reversing that shunt. So instead of going from right to left, you're going from left to right again, which is improving the hypoxia, and it's also minimising the chances of clot going into your brain. And then finally, ECMO buys time for heparin to work. Thrombolysis can be used, but it takes time to be effective. And we know that most deaths from PE occur in the first 2.5 hours. And the biggest cause of death in these patients is shock. So if we can get onto it early with ECMO and then think about the treatment, then they're going to have a better outcome. Okay, so VADS. VAD stands for Ventricular Assist Device. There are an increasing number of VADs being used as a bridge to transplant in the setting of advanced heart failure. And we do come across them as a service. There is an ambulance protocol when they're in cardiac arrest. And I think we come across them once or twice a year. So I think it's important as a group we understand what to do when we come across these patients. The overall 1-year survival with a VAD is about 81%, and 2-year survival is about 70%. So there's more and more of these patients roaming around the community. VADs can be placed in the LV, the RV, or both. Now, the most common form of VAD we're going to be seeing in the community is an LVAD in the left ventricle. It has 3 different internal components. So you've got the inflow cannula that drains from the LV and it decompresses the failing ventricle. You then have the pump, and that blood that's drained from the LV goes into that pump. And then you have the outflow conduit. That's anastomosed to the ascending aorta, and blood is pumped from that pump into the aorta. So similar to an impeller. Then you have the external components. You've got the controller that's connected to a power source, obviously, and it controls your settings like flow and RPM. And you've got the drive line, which actually goes into the patient. You can see the skin entry site on this diagram. And that is basically connecting the external controller to the actual pump on the VAD. So your operation of your VAD is going to really depend on whether or not that drive line is securely connected and whether or not you've actually got power going to the external controller. So let's talk a little bit about the physiology. It's a continuous flow system, and what that means flow will continue throughout the entire cardiac cycle. There's no diastolic filling or systolic filling, so systolic ejection, so it's going to be non-pulsatile. Because of that, the system is going to be preload dependent. The LVAD can only really suck and pump the volume it receives from the LV, and it's going to be afterload sensitive. So for a fixed pump speed, a fixed RPM, flow is going to go up and down depending on the afterload the pump has to push against. So when we're assessing these patients, there are some key things to remember. The patient themselves or their relatives is probably going to be your best bet about finding out information, and they're going to be the most useful source of information. So talk to them first up. The lack of pulsatile flow obviously makes it challenging to assess for peripheral pulses, and you won't be able to get an NIBP or a pulse oximetry sometimes. So you'll have to put an art line in. That's obviously difficult to do pre-hospital. So you can use a Doppler with the NIBP, and the first Doppler signal normally correlates with the map, or you can try and put an art line in. Your hemodynamic assessment is going to include a physical assessment of the patient as well as an assessment of the VAD. So your physical assessment in the pre-hospital setting, I think the best thing to do is just look at them and assess the useful signs of perfusion, like their capillary refill, their colour, their mentation, if they've got worsening urine output, if that's possible to talk to them about that. If they're awake and talking to you and they're well perfused, then the device is working. Then we want to have a look at our VAD. So the pump function's assessed by making sure that the pump is still running. That's done by auscultating over the precordium and then listening for this continuous hum. The device controller is the next thing that you want to look at. The device controller will display some of the information that may give you a clue as to what's going on. You can see this on the screen. What happens is and they'll set the RPM, and that RPM will be fixed, and the flow will go up and down depending on the loading conditions. So you want to see whether or not they're achieving a decent flow. So anything above 3.5 litres is a win. And if it's dropping, then they may need volume, or the afterload might be high. You want to have a look to see if the battery's charged by pressing the battery display button, because that can be a common gotcha. Next, you want to have a look at the drive line, and you can see on the screen a picture of the drive line being inserted into the abdomen. That usually exits at the right upper quadrant, making sure that the LVAD's being powered and controlled from an external source. So ensure that that drive line is intact, that there's no exposed leads, and make sure that the connections are properly secure. Now that we've done our assessments, we want to go through VAD emergencies. So cardiac arrest management. It's obviously going to be really different and difficult to do from a normal cardiac arrest, and the focus is going to be on troubleshooting the machine first up. So have a look at the patient's mental state, have a look to see if they're breathing. If there's agonal breaths present, assume that the LVAD is stopped and proceed on to your assessment of circulation. If they're breathing normally, then you can probably start to think about some respiratory causes of their low GCS. Then you want to look at their circulation. So don't delay treatment by trying to find a pulse, because you won't find it. You want to be looking at the patient, and then you want to listen and feel. So when we look, are they unresponsive? Is there apnea? If yes, then they're probably in circulatory arrest. LVAD failure doesn't necessarily always cause circulatory arrest though, so the patient may still be breathing but look gravely ill because they've got some underlying native function there. But it's important to still obviously check that the LVAD is running. You want to listen. Usually if the VAD has stopped running, there'll be a loud alarm coming from the controller, but also listen over the precordium and make sure that you can hear that hum, because the LVAD has definitely failed in the absence of that hum. You want to feel. So if the pump stoppage occurs when there's complete loss of power for the pump, so check your external components of the VAD. Check that the connections to the controller are secure, that the power leads and driveline are fully engaged, and check the batteries are charged, obviously. Now, if these measures fail to restart the VAD, then it's presumed that the controller is defective, and they should have a spare controller attached to them. They should carry it with them at all times, and you want to then connect that to the driveline. So remember, some of these patients may have myocardial reserve, and if all else fails, you can try and limp them along with adrenaline and adrenaline boluses and an adrenaline infusion to try and get that native function happening without the VAD. But if all of that fails, then you have to go down your ALS algorithm. If they're in VF or VT and unresponsive, you need to shock them. And CPR is controversial. Now, our ambulance protocol says to commence CPR. We're not to use a Lucas for obvious reasons. There is some concern by doing CPR that you may dislodge or cause an anastomotic rupture. But, you know, they're obviously in cardiac arrest, so anything you can do to try and get a cardiac output, I think, is probably better than not doing CPR. Just don't use the Lucas. And then finally, if we go to those patients that are hemodynamically unstable, your hemodynamic goals are going to be a MAP of less than 80, and hypotension is going to be defined as a MAP less than 60. Preload's really important in these patients, so when in doubt, give them volume. The pump has no way of assessing the volume in the LV. So if the patient's volume depletes, then the LVAD's not going to compensate by increasing its RPM or cardiac output like your native heart does. So when you have no volume in the LV, the pump's going at a particular speed, and what happens is the tissue in the LV starts to get sucked into the pump cannula, and you're going to obstruct your inflow. So you want to kind of give volume to open that up and release the tissue from in the cannula. So factors that will result in a preload reduction are obviously need to be eliminated: bleeding, RV failure, tamponade in particular, and obviously sepsis. And finally, we want to look at our afterload. So increasing your afterload can lead to the heart failure symptoms because the LVAD again is set at that fixed RPM, so it cannot compensate for a high afterload. So you want to have careful consideration in these cases to starting vasopressors. I would cautiously start, if they're unstable and hypotensive, a low dose adrenaline and very slowly titrate my way up, depending on what the flow on the VAD is doing. And if we have extreme hypertension in these patients, it can actually stop the flow through the VAD, which can lead to pump thrombosis. Bleeding is probably the most common adverse effect from these things. It's about 40% require hospitalisation for bleeding. And the common sites of bleeding are actually in your gut from malformations, epistaxis, intrathoracic bleeding. And the causes are not von Willebrand's syndrome because of the blood going through the pump, and obviously platelet dysfunction. That reduced pulse pressure that is associated with the VADs actually increases these formations of arteriovenous malformations and angiodysplasia in the GIT tract, and that's kind of what causes the GIT bleeding. Arrhythmias are also common. About 50% of these patients will have arrhythmias, but it's okay because they've got a VAD in and they're going to cope. But you kind of want to shock them out of it if you can, particularly if they're unconscious, to try and establish an organised rhythm. You can use your usual antiarrhythmics if you need to, like amiodarone, and as I said, cardiovert them if they're unconscious. Transporting these patients, it's complex. You want to be doing it in consultation with the heart failure team at St Vincent's. When you are transporting them, you want to make sure to take a spare battery and all of the components of the VAD with you. So make sure you've got that second controller as well. And I would probably consider taking the patient's relative with me in the helicopter or the ambulance, because I think they're going to be the best source of information and troubleshooting at the end of the day. And that is all from me.
Lovely. Big thanks. Any questions from the team?
We've got a question from, of course, someone halfway up the auditorium.
Keep walking. Sorry. Hi, Nat. I'm just wondering, if you need to shock the patient, is there any considerations on pad placement in relation to the device? Do we need to place them standard positions?
Yeah, standard position. Yeah.
How would they even know they're in VF?
The patient?
Yeah.
Well, it depends on how much native cardiac output and how much flow is actually set to the VAD and how much support they're needing. So some patients will tolerate a VF because they're on a lot of support. Some patients obviously won't, and they'll become unconscious.
What does the outline trace look like, Nat, if they've got continual flow?
Oh, you'll only get a map. That's all you'll see on the outline trace. So it'll wave a little bit, but all you'll see is a map.
Thanks, Nat.
Is pericardial effusion a likely problem in these patients, because you've got the systems going outside the pericardium into the heart?
Yes, it is, and that's one of the things you need to look for is tamponade as a cause for hypotension.
Are they routinely anticoagulated and like,
which can be troublesome?
They come off it and all that sort of stuff.
Say again.
Obviously, they might self become non-compliant with treatment if they've got bleeding issues and other sorts of things. So that PEs and clots and other sorts of stuff might be the other side of the issue if they. Yeah.
And pump thrombosis. So that'll stop the pump working too.